Hello, I am Tina Paul. I bring you greetings on behalf of the Suffolk Alumnae chapter of Delta Sigma Theta Sorority Incorporated. Welcome to the third form of our Black Health series. Today's topic is geared towards women advocating for their health and maternal mortality. As you know, many of us dedicate our time and life to taking care of family and others, often neglecting our own personal well-being in the process. Then there are times when we seek help or medical attention, our needs may not be fully met. Today's presenters, both medical professionals, will provide insight on why we as Black women should advocate for our health and how we should go about doing so. We will receive valuable information on how to care for ourselves during pregnancy and what can be done to reduce high maternity mortality rate among Black women. Thank you for tuning in to join our Black Health series. At this time, Ms. Erin Banks, a member of the Suffolk Alumnae chapter, will introduce our first speaker. Ms. Banks?
Our first speaker is Dr. Monique Crabb. Dr. Monique Crabb is a native of Chesapeake, Virginia. She received a Bachelor's of Science in Biology from James Madison University and a doctorate in medicine from Eastern Virginia Medical School. Dr. Crabb went on to complete an obstetrics and gynecology residency at the University of South Florida in Tampa. She has been in private practice with Complete Women's Care in Virginia Beach for almost 16 years. Dr. Crabb became a member of our illustrious sorority through the Iota Alpha chapter of James Madison University in 1994. In her free time, she enjoys spending time with her husband and 2 daughters and traveling. Dr. Crabb.
Thank you for that lovely introduction, and I hope to be able to share a little bit with you today about an increasing awareness of increased maternal mortality risks associated with Black women. So if you could please start my slides. All right, thank you. We're going to start with a little background. More and more data has come out and through the CDC. It shows that the United States continues to have the worst maternal mortality rate among industrialized countries, despite advances in modern medicine that have overall brought down maternal mortality rates. Pre-20th century, pregnancy and childbirth was a leading cause of death amongst women of childbearing age. Maternal mortality is defined as death during pregnancy, childbirth, or up to 42 days postpartum. The reason for the continued high mortality rates in the United States has been attributed to inconsistent obstetric practices, an increase in women with severe or multiple comorbidities prior to pregnancy, and a lack of complete maternal health data. Currently, and this is 2017-18 data, the US maternal mortality rate is about 17.4 per 100,000 women. Next slide, please. The top 5 reasons for maternal death have really not changed all that much, but the leading cause is hemorrhage. Next, infection, typically after delivery. So the women who die in those 42 days following delivery. High blood pressure, more specifically related to preeclampsia and eclampsia, the pregnancy-related high blood pressure conditions. Complications from delivery, which would be, besides hemorrhage, during a C-section, a complication that occurred during a C-section that later led to maternal death, something called amniotic fluid embolism, which is dangerous and pretty uniformly fatal, but not really preventable, very rare, but something that has to do, that's only associated with pregnancy. And finally, unsafe abortion, although since the legalization of abortion, that has decreased some, but for women of color and poor women, this is still quite a safety issue. These top 5 reasons for maternal death account for about 75% of deaths. The remaining 25% relates to accidents, domestic violence, other diseases that complicate pregnancies. Say if a mother developed cancer during her pregnancy, things like that account for the rest of the deaths. Although data is still being collected, COVID-19 has posed a somewhat significant impact in that women who are pregnant are more likely to develop severe illness and die from COVID-19 than men or women of similar age and previous health status. Although the overall maternal death rate in the United States has improved over time, the gap between white women and Black women has continued to widen. The maternal death rate for Black women in 2019 was noted to be 3 to 4 times higher than for their white counterparts. The CDC pregnancy surveillance study showed that Black maternal mortality was also due to a higher likelihood to die from pregnancy complications, as those 5 top things that I listed in the previous slide, not because it's more likely to happen to a Black woman per se, but with similarly matched white women, a Black woman, despite socioeconomic or other differences, it's just more likely to die in the same instance. Next slide, please. So why, do you ask? There's such a disparity still in 2021. Well, we have to look back at historical reasons, and certainly this is rooted in racism, access to care, and socioeconomic status. Those all go hand in hand, and they continue to be a problem due to healthcare deserts, meaning places that are still chronically underserved as far as access to high quality medical care, which is also linked to access to insurance coverage. The other racial aspect is still skepticism of many Black people in the community with the medical establishment for very good reasons, as well as access to early care continues to be a problem. The incidence of pre-existing conditions, again, we go back to lack of overall good health care. So Black women who are also more likely to be poor and disenfranchised are more likely to have pre-existing conditions that are either poorly controlled or even undiagnosed, and these conditions will also often be exacerbated during pregnancy. Medical racism, this is a whole nother category of racism by itself, where Black people are often undervalued, their complaints are not acknowledged, and there are just certain pre-existing conditions that we are more likely to have that are not acknowledged, and when this is ignored, it leads to poor health outcomes. And finally, access to safe pregnancy termination. Again, that is a problem, especially in some of our southern and more conservative states where public funding to Planned Parenthood, having clinics that will provide this safe option for women who desire it, but it also goes hand in hand with poorer access to reliable contraception. Access to reliable contraception decreases the risk of unplanned pregnancies, which directly decreases the need for pregnancy termination. Next slide, please. So what is being done overall to help decrease maternal mortality? California's done a really good job with attacking the #1 cause, which is postpartum hemorrhage, and implementing hemorrhage protocols, which include carts that contain all of the necessary medicines that we need, protocols that initiate early interventions that even the nurses can initiate before a doctor is on hand, just so that everybody sort of knows what to do right away, and also being aggressive in acknowledging and treating the hemorrhage. Prophylactic treatment in high-risk patients, women who have been in labor a long time, who've been on oxytocin, who have been infected, who have larger babies, who've had 4 or more babies, are more likely to hemorrhage. And so having a higher index of suspicion in these cases goes a long way in preventing the hemorrhage, as well as being in a center where quick resuscitation with IV fluids, access to anesthesia, procedures to stop hemorrhage as necessary if the medical modalities don't work, as well as quick access to not just whole blood, but other blood products that will help prevent dying from the hemorrhage. And this is a problem in smaller hospitals in more rural areas that we're also trying to address. The other thing, the other disease that is very prevalent and causes increased risk of death are hypertensive emergencies of pregnancy, and initiation of protocols not only to identify during pregnancy and early in pregnancy patients who are at higher risk, closer monitoring throughout the pregnancy. So a woman who is already hypertensive prior to pregnancy and on medications, very young pregnant patients, older pregnant patients over the age of 35, pregnant patients who have diabetes, heart disease, kidney disease, all have an increased risk of having hypertensive exacerbations during pregnancy, and should be started on a baby aspirin starting at 12 weeks of pregnancy, as well as have closer monitoring of their blood pressures, changes in their baseline blood pressure, fetal monitoring in the 3rd trimester, and also potentially scheduling of their delivery so that things are done in as controlled of a circumstance as possible. So if you are entering pregnancy and have any of these health issues, it's a good conversation to have very early with your medical provider. Of late, we've heard a lot of discussion about insurance and access to medical care, and there have been increased expansions of Medicaid to pregnant women to allow for early care, because unfortunately, a lot of women of childbearing age who are not previously insured during pregnancy is the only time they really have good access, regular access to care. And many times pre-existing conditions are diagnosed and treated for the first time. So that is very important to expand Medicaid in not only during pregnancy, but for it to continue afterwards as necessary. Because as we know, that next 6 weeks after delivery is also a very precarious time. Next slide, please. Medical racism and implicit bias. These kind of go hand in hand. A 2016 studies showed that white medical students believed that Black patients have a higher pain tolerance than white patients. This is in part due to centuries-old misinformation based on, observation of slaves and assuming that they had thicker skin, less sensitive nerve endings, and stronger immune systems. A lot of this probably came from the fact that it was absolutely amazing that so many slaves survived the Middle Passage travel and then survived and even somewhat thrived. I don't know if that's really the right word, but didn't die off despite continued very inhumane treatment, poor nutrition, and continued to persevere on. And it was thought that this was due to more animalistic, subhuman traits and subsequently less sensitivity than other races. Dr. J. Marion Sims, often dubbed as the father of modern gynecology, infamously perfected a technique for vaginal fistula repair. This is a condition that often is associated with childbirth, where tears occur in the vaginal walls and don't heal properly, and it can cause a communication between the vagina and the rectum, where stool will actually pass through the vagina. It's a very common problem in third world countries still today. He practiced in Alabama and sought out enslaved women from plantation owners to essentially perfect this technique on the women without anesthesia. And it's just recently that this has become very common knowledge. He had a statue, discussing his accolades that was previously up in Central Park in New York, but it was removed pre-COVID, and the plan was to replace it and honor the 12 women that he so terribly used to perfect his technique, to honor them in some way, but that has been put on hold because of COVID. But hopefully now that things are getting better, these women will actually be revered and honored for their part in this and be acknowledged properly. Next slide, please. As a result of this terrible history, Black people are less likely to have pain adequately treated in the emergency room, less likely to be admitted to the hospital, and more likely to die in the emergency room or during hospitalization than their white and Asian counterparts, wholly because their complaints are not taken as seriously. And this is why Black mothers are still more likely to die during pregnancy and childbirth, even when socioeconomic issues and access to care are removed. We all famously know or heard of Serena Williams and her issue of a history of blood clots, where if you have that history prior to pregnancy, then certainly pregnancy is going to make it worse, as well as having surgery. And she did undergo a C-section, which puts her at high risk. And when she complained of similar symptoms of a pulmonary embolus, her concerns were essentially blown off. And if someone as, who supposedly you would think had the best medical care is not listened to and acknowledged when she already came in with all these risk factors, that says a lot about how far we need to go in acknowledging these problems. Next slide, please. So what now? Many medical schools and healthcare systems are providing training on implicit bias to try to combat this, but it's going to be a very slow uphill battle. Having more people of color pursuing medicine is helpful, but it's only a small part of trying to rectify this issue. Addressing healthcare deserts, which are in rural and inner inner city communities is another way to help address access to care for women of color, because although Black women are disproportionately affected, Hispanic women also have issues, especially those who are undocumented. Increasing access to reliable contraception. Pregnancy is inherently dangerous to anyone, and it's more dangerous to those with certain health issues. So reliable access to contraception and being able to plan pregnancy adequately is very, very important. Early access to prenatal care to optimize one's health at the beginning and throughout a pregnancy, as well as I mentioned before, access to safe pregnancy termination is if that is maternal choice. Diagnosis and treatment of chronic medical problems prior to pregnancy is also huge. And a lot of this goes back to having adequate and full coverage healthcare. In a lot of states, as far as Medicaid, women who are not pregnant, it is very difficult to be covered by Medicaid. And sometimes it only provides coverage for annual well-woman exams, which is good for providing contraception, but in women who also have other chronic medical conditions, this is sometimes inadequate. So this is another place where we could use improvement. For those women who do not have issues with access to insurance and medical coverage, it is important to make sure that your health is as optimized as possible and having a preconceptional discussion with your physician prior to attempting pregnancy. Many women don't really know what some of their risk factors may be. And so that's why it's good to have the discussion with your healthcare provider before attempting pregnancy. Patients need to be empowered to advocate for themselves and be heard by healthcare professionals. This is where it goes back to also rebuilding trust between the Black community and healthcare professionals. You should never leave an appointment feeling unheard or belittled. If that ever happens, then that's not the healthcare provider for you. As I mentioned before, it is helpful that there are more people of color entering the health profession, but we still only make up so much of the population. And it is important to continue to educate all healthcare professionals that they need to be sensitive and aware of the entire population, and equal treatment doesn't necessarily equal care. It is important to address some inherent differences between different patient populations to help better serve them. And that is something that we are trying to address with medical training at all levels, whether it's at the physician level, physician assistants, nurse practitioners. There are many mid-level providers out there that are the first line of care for many patients. So these are all works in progress, but today, as many of you who are listening now, things that you can do to help advocate for yourself would be ask questions. If you don't understand something, stop your provider and ask the question. And if the answer is not suitable, ask again. There's never too many questions. There's no such thing as a dumb question. And if your provider makes you feel that way, again, that's a time to reevaluate your relationship. It's important to have a very high level of trust in your healthcare provider. And it is absolutely your right to want and demand that. Next slide, please. So there's me and my motley crew before the Christmas before COVID, and we had no idea what was coming down the pike for us. Thank you for your time, and I will now take questions.
Thank you so much, Dr. Crabb, for all that great information. Good afternoon. My name is Shay Skinner, Committee Chair for the Suffolk Alumnae Chapter of Delta Sigma Theta Sorority Incorporated. We're now open for any questions for Dr. Crabb. Dr. Crabb, you did fully explain a lot of information, but I'm gonna see what questions we have to present to you.
Thank you.
Now, I do have one. Now, even with commercial insurance, there are many barriers for trying to receive certain care while pregnant. How can you advocate if you have any concerns? Do you take it directly to your physician to try and help you? Or what is the best route to take for advocating when you have concerns on whether how your pregnancy is going or for the baby and insurance is a barrier?
I guess you're saying if insurance is a barrier or insurance is not a barrier?
Well, both would be great, but probably if insurance as well is a barrier, because sometimes, you know, maybe Medicaid or commercial insurances, and they're really cracked down on maternal health.
Correct. So I'll start with if insurance is a barrier, because we do have the issue of many women presenting late to care because it can sometimes take 4 to 6 weeks for Medicaid to become approved. And sometimes different offices will not accept you until you have active insurance. So in that instance, it is important to maybe look for different offices that will take you with Medicaid pending, or check with your local health department. Sometimes you can initiate care relatively quickly there, as well as Planned Parenthood. That's a very good resource for early pregnancy, for diagnosis, for pregnancy counseling early on. They don't follow you for a long time, but through the first trimester and early second trimester, Planned Parenthood is actually a very good option to establish care and may even help grease the wheels, so to speak, in trying to get in with another physician, as well as your local health department. If you do have commercial insurance, that's where trying, if you can, having a preconceptional discussion, whether it's at your annual and you're thinking about having a baby within the next year before you come back for another annual, or you had your annual 6 months ago and you just have questions, you can often schedule a short preconceptional counseling session with your physician. And we now even do those via telehealth to discuss your risk factors. And if you had some other health issues, talk about optimizing those prior to pregnancy, getting you in with specialists as necessary to help optimize, like if you're diabetic, making sure your diabetes is as under good control as possible. If you're hypertensive or on certain medications for your hypertension, making sure you're on a medication that is conducive to pregnancy, because some of them aren't, and you may need to have your medication changed to make sure you're stable on it before conceiving. Maybe even having a consult with the high-risk pregnancy specialist, maternal fetal medicine, if you have other certain genetic conditions that you're concerned about, if you're concerned about passing on certain genetic conditions to your future children. These are all things that can be discussed prior to pregnancy. Now, we all know that 30 to 40% of pregnancies are completely unplanned, and that's okay. What's important is to try to get in as soon as possible. And even if you have an established OBGYN, you can get in for a very early pregnancy problem visit as necessary if you do have any pre-existing conditions that you know about. Otherwise, it is relatively easy to get in early. Most practices will get you in within the first 8 weeks. After that, as far as navigating any conditions that develop during pregnancy. We do have the maternal fetal medicine doctors, or if you had a clotting issue, we would refer you out to hematology. So that would just be a conversation that you would have with your healthcare provider. And also, I guess it's also very important prior to pregnancy, making sure that your insurance has maternity coverage. A lot of women, unfortunately, find out after they're pregnant. They're like, oh, I have insurance, but their insurance does not cover maternity care. And that's the same as being uninsured. So that is something to look at prior to pregnancy. Sometimes you will qualify for Medicaid potentially if your insurance does not have maternity care coverage, or if you have a high deductible insurance. These are things to look at to help decrease access to barriers, or access to care later. Did I answer the question?
You did. Thank you so much. That was very thorough and complete. And I have one more question. It's not as much as advocating, but I guess just a general question. Reference to COVID shot during pregnancy. Any thoughts, suggestions?
Yes. So this is a big quagmire. The American College of OBGYN has come out with a statement that although all three COVID-19 vaccines from Pfizer, Moderna, and Johnson & Johnson are considered generally safe in the population, there are no strict guidelines or recommendations on safety in pregnancy because we've had no direct studies. However, we've been vaccinating people, including pregnant women, since December, and there have been no adverse health outcomes directly related to any of the vaccines to the pregnant mothers or their babies, because at this point, we also have babies being born to mothers who are vaccinated. There is some encouraging data showing that antibodies are being formed from the pregnant mom that are passing to the baby through by checking the cord blood on the babies. So there is evidence that babies may be getting some passive immunity in utero that may be helpful to them after birth. We don't even know how long the COVID vaccine will keep an adult human safe, but it has been, if the babies are getting some sort of immunity, then that is helpful. The same goes for breastfeeding. The theory is that the antibodies produced by the mother would get into the breast milk, just like with any other antibodies that convey passive immunity to the babies. So it is also considered generally safe in breastfeeding, but we don't have any good long-term data yet, but it does look very promising as we continue to go forward. And like I said, there's nothing dangerous that we see thus far. What is good about these particular vaccines is that there is no live virus, so you can't develop COVID or give COVID to your infant. It's generally thought the vaccine, if you feel comfortable with taking it, is better than taking your chances with COVID-19 infection.
Awesome. Thank you so much, Dr. Crabb. We're going to go ahead and conclude this session for questions. But if there are any further questions, please direct those to sacdst.org, and we will make sure we get them to Dr. Crabb. Dr. Crabb, thank you again. We really appreciate all the great information.
Thank you so much for having me today.
Yes, ma'am. I'm going to pass it back to Ms. Banks to introduce our next speaker for this summit. Thank you.
Thank you, Dr. Crabb, for all of your very helpful information. Our next speaker is Lakila Powell. Lakila is a 2006 graduate of Virginia State University, where she majored in biology. From there, she completed her master's in physician's assistant studies in 2009 from Eastern Virginia Medical School. As a physician's assistant, Lakila specializes in family medicine, and with a desire to give back, she started the first 10 years of her career working in community health centers, serving those who were uninsured, underinsured, and migrants. Currently, she has an amazing opportunity providing medical services to our veterans and their families at Langley Air Force Base. Outside of serving veterans and their families, Lakila is a medical officer for the Virginia National Guard with 10 years of combined services between the Army and Air Force. As a citizen soldier, she has had the opportunity to be of service to several groups that she feels have been overlooked in society: the uninsured, the underinsured, migrants, veterans, and current military service members. She believes that healthcare is a right, not a privilege. Currently, she is working towards her doctorate in public health at Capella University with research interests in racial disparities and inequalities and how we can combat structural racism to improve healthcare. She believes that each of us has a social responsibility, and the blessings that have been afforded to her, either through her education or career, are not about what she can do, but how she can help others. Lakila.
Good day, everyone. My name is Lakila Powell. I am a physician assistant, as previously stated, and I am truly excited to be able to share with you a topic on advocating for your health, which I feel is very, very important. The reasons that we found this to be important for our discussion amongst our Black Health series is that, one, African Americans remain the least healthy of any other ethnic group in America. And while slavery was over 300 years ago, its legacy of structural racism, implicit biases, marginalizations, and medical distrusts are still felt in our communities as African Americans experience illnesses and infirmities at extremely high rates, and have lower life expectancies than most racial and ethnic groups. And secondly, while we cannot change the views of others, we can change how we respond by knowing that we have the power and rights when it comes to our own health. As the title suggests, no one knows you better. No one knows you better than you, and you're the best advocate for your health, not just because of your health, but your family health and those that you love. There are several things that we're going to be discussing today that I feel that are very important so that you can become the best advocate for yourself. And that is about how to build relationships with your medical team, how to establish trust, and knowing your rights. But before we go into those things, one of the things that I do want to share with you is why it is important, okay? So can you please go to the next slide for me? So all of the statistics that we're going to be going over comes from the U.S. Department of Health and Human Services, the Office of Minority Health. So first things first, African American women. Dr. Crabb gave a great talk on maternity mortality rates. And one of the things that she actually brought up is the comorbidities that can lead up to them. And one of those is obesity. African American women have the highest rates of obesity and being overweight compared to other groups in the United States. About 4 out of 5 African American women are overweight or obese. People who are overweight are more likely to suffer from other conditions that they're more predisposed to, such as high blood pressure, high levels of body fat, diabetes, bad cholesterol, and all these risk factors can lead to heart disease and strokes. In the case of hypertension, or what most people know as high blood pressure, African Americans have significant higher rates of hypertension. However, we are the group that has the least amount of control over hypertension. In cases of diabetes or high blood sugars, African Americans are 60% more likely to be diagnosed. However, we are more likely to have a worse prognosis in that we may develop end-stage renal disease, which most people think about when you go into dialysis. And we're also more likely to be hospitalized for lower limb amputations. Can you please forward? Also, there are other viruses that are out there that we are more predisposed to having worsening outcomes. So hepatitis, for instance, African Americans are 1.5 times as likely to die from viral hepatitis as compared to non-Hispanic whites. African Americans are almost twice as likely to die from hepatitis C as compared to the white population. Now, while we do have comparable rates of hepatitis B, African Americans were 2.6 more times likely to die from hepatitis B than other ethnic groups. HIV has been something that has tormented our community for years. As far as African American males, they have an 8.6 times the rate than white males. African American females have an 18.6 times the rate of AIDS rates than white females. African American men are also 6 times as likely to die from HIVs or AIDS as non-Hispanic white men. And there are also, the women are 18 times as likely to die from HIV/AIDS as non-Hispanic white women. In 2016, African Americans were 8.4 times more likely to be diagnosed with HIV infections as compared to the white population. And then final thing on this slide is just in regards to infant mortality. So Dr. Crabb, she did great with maternal mortality, but on the flip side of that, we also have alarming rates where our children, the infants, are also dying as well too. So African American babies have a 2.3 times the infant mortality rates than any other ethnic group. Those infants are 3.8 times as likely to die from other complications that are related to low birth weight. Can you please go to the next slide? Now, mental health in our community are often dismissed many times because of fear of looking weak or having little faith. But the fact of the matter is that mental health is real and we are all human. Now, we just spoke about infant mortality rates. And as mothers, how would that make you feel if you were to lose a child? Okay, those things have an impact on our mental health. Particularly more concerning about this section is that last statistics, where actually the US Surgeon General, where they found that between 1980 to 1995, the suicide rate among African Americans ages 10 to 14 increased 233% as compared to 120% of non-Hispanics whites. Now, think about how these numbers may increase as we're living in the midst of the pandemic and all the social and political unrest that our children are now facing in this country. And lastly, asthma. I firmly believe that in regards to asthma, there's no reason why anyone should die. And I probably feel more strongly because my first patient in primary care that actually died on me was a 13-year-old African-American female. And it was no reason for it, okay? But however, in 2019, African Americans are still almost 3 times as likely to die from asthma, with children being 8 times more likely to die from asthma than other kids in ethnic groups. Now, there are so many different barriers that we can say that can lead to this, from education, health literacy, where people live, the environments that they live in, not being able to have sidewalks and things of that sort. But these are just the whys. And while no single one of us can address all the systematic or structural barriers alone, the one thing that we do have control over is being able to advocate for ourselves and being an advocate for those that we love. So the first thing about advocacy, in my opinion, is being able to build a relationship with your provider. And so please forward. So when it comes to building relationships with your provider, I think it's very important to understand that you do have different types of providers. You have PCMs, or primary care managers, and you have specialties like OBGYN, cardiologists, endocrinologists, or gastroenterologists. Now, with each one of those, they do have different criteria, so to speak. And so I definitely believe that not just because I'm a primary care provider, that everyone should have a primary care provider, but you really should. And the reason is that primary care provider is kind of like the glue to your health. Their responsibility is to make sure you get plugged in with whoever you need to get plugged in with, whether it is the OBGYN, whether it is the cardiologist or the rheumatologist. That's their goal. And with them, they can kind of help put the puzzle together. Okay. And so I tell people, as a primary care provider, we know a little bit about everything, but we're not specialists. That's why we send you out to make sure you get the experts in those areas that you need care with. Okay. Now, you may not like all the specialists that you get referred to, but if nothing else, your relationship with your primary care doctor or provider should be the best relationship you have with your medical team, because they're going to be able to get you where you need to go. Now, we talked a little bit, Dr. Crabb talked about a little bit about access to care when it was explained what you do as far as like not being able to have insurance and things of that sort. And some people may feel that, how do I establish with a primary care doctor if I don't have access to care or if I don't have insurance? But the fact of the matter is there are so many different ways that you can get plugged in. But I do believe that people don't know because they just don't know. So, you have the health department. Now, sometimes there are preconceived notions about health departments, but I think that health departments sometimes have some of the best providers out there, and they are really in the trenches trying to help those who don't have insurance. You also have community health centers. I worked in one for 10 years, and I thought it was probably the best place to work ever. Now, with community health centers, they are actually able to see people who have insurance and who don't have insurance. They may put you on like a sliding fee per basis based off your income, but it is still a good place to get you set up. And a lot of times, even in those community health centers, they do have specialties like pediatricians. They may have dentists there. Where I worked, we actually had an OBGYN. So there's no reason that no one should have a primary care doctor, okay? Now, when it comes to providers, remember that we are people just like everyone else. Okay, no provider is going to be the same. And so it's very important that as you're building a relationship, that you find someone that's going to mess with your personality. You have providers that may be very, very direct. Okay, but you may need a provider that's going to hold your hand and pray with you. Okay, you have to be able to know what you need and what your personality, what you need as far as your comfort level. Some people like people that are more direct. And those people, I'm not that person where I am more of a provider where I will hold your hand, I'll hug, we're going to pray in the office. Some people don't like that and don't need that. So you find that person that's going to give you what you need. And then the other part of building that relationship is just understanding that there is elements and there is importance when it comes to continuity of care. That is probably one of my big things in healthcare. Just because it does make a big difference when the person that you're seeing, you've been seeing them over and over and over again. As a provider, I know you. I already know what we already done, where we've been referred to before, what medications that's been tried. And as a patient, by having that continuity of care with the same provider, that prevents you from having to go and elaborate your story and your condition to another person after another person after another person. So there is an importance when it comes to continuity care. Now, when I talk about continuity of care, do understand that I'm talking more so when it comes to these chronic conditions like the hypertension, the diabetes, and things of that sort. You do want to try to stick to the same person once you built that relationship with them in regards to being able to take care of you. When it comes to urgent care matters, then okay, see another person or go to urgent care. But when it comes to those chronic illnesses, try to keep up with the same provider each time. The second aspect is just about in regards to being able to establish trust. Can you please push up the slides? Thank you. And so trust in any type of relationship is important. We know that whether it is a romantic relationship, whether it's a relationship with our kids, with our friends, trust is valuable. And so I tell people, don't be blind when it comes to trust, okay? And do not overlook the authority or go by titles that a person may have. And so just because someone is an MD, a PA, or a nurse practitioner, it doesn't necessarily mean that that is the person that you can trust. Okay. And so to be able to build that trust, you have to make sure that you're asking questions, making sure that they're on the same page when it comes to your care as you are. You may have to go and do some reading on your own. Remember, this is your health, and no one is going to be more concerned about your health than you are. Okay. And so it may take that you have to read some boring medical studies or journals about your medical condition. May mean that you might need to go and find some resources out in the community for yourself, but it's about making yourself knowledgeable, okay? And when it comes to that trust level by making yourself knowledgeable and not being blind, that opens up the doors where you can find out, okay, I want to do more of like a natural basis. Is this provider going to be able to help me out with that? Are they just going to push medicines towards me and not think about the mental aspect or my other concerns that I have with not taking medicines? The other thing that I would definitely say when it comes to not being blind is making sure that you do your own research. And that comes back to the medical studies and stuff. But your best defense for yourself when it comes to speaking to a provider is being educated on the matter. Okay, do your research before your appointments. That way you're more prepared and you can ask questions. And so with being prepared, it's about just figuring out what things that you want to take place during that visit. Okay, now I'll be the first to say, sometimes it can be a little bit of a time crunch when we're in the office. But have those questions written out and don't let anyone make you feel rushed when it comes to getting your questions answered. And if you're not able to get them answered then you should be able to ask your provider and be comfortable enough with asking your provider, hey, can we set up another appointment because I still have some other questions? Or most practices today, they have some type of secure messaging where you're able to do communication with your providers through a messaging system. Say, hey, can I just send a list of a few questions so I can get those answered? Okay. Most people, they won't turn you down or anything, but you want to make sure that all your questions do get addressed at some point. It may not be at that one visit. It may take a couple of visits to get that established. And then you want to be prepared. Okay. Have your lab results from your other providers. Because one thing that I can say from primary care is we can send you to a specialist, but it doesn't mean that necessarily you're going to send your notes back to us before your next appointment. Okay. So then that contributes to us having to do our own and more research for you. We may not have everything from the other provider before you come into us. So ask all of your providers, keep a notebook, put your labs in there. Ask for copies of your notes. That way you have your own record. You can monitor your own changes in your labs and things of that sort and ask questions. You may not know exactly what it means, but most of us can tell if something has increased, decreased, or changed. Okay, so have that information available to yourself. I'm a big proponent, again, of just trying to have patients be more in tune to their own health. And I start that even at the age of 12 when it comes to my patients. And I encourage them and I encourage you all to at least have a notebook, not just with your labs and things like that in it, but have a notebook when you come into your appointments to be able to write down those questions, be able to write down the answers that's given to you. That way you can go and look it up later, okay? You may not know all the words that's being published or that's being used, but we can always find those things, and Google is a good tool these days. Now, the last thing on this thing about establishing trust is just knowing that you have to do your part too, okay? Trust is a two-way street in any type of relationship. You have to be able to trust your provider, but as a provider, we have to be able to trust you as well too. Understand that we're giving you information. We can't go home with you. Okay, we need to trust that once we come up with a plan together, you're going to go home and implement that plan. We can't chase you down and say, I need you to take your blood pressure pill. Can't chase you down and say, I need you to not eat those French fries or eat that luncheon meat. I need you to go outside and, work out for 30 minutes. We have to trust that you're going to do your part on things as well too. Okay, so just be reminded of that. You expect from your doctors things and you want to have trust with your doctor or your provider, but we also need to make sure that we trust you to go home and implement those plans. Can you please forward to the next slide? Now, what we get when we have trust and we're able to build a relationship is definitely we're able to get better outcomes. When it comes to hypertension, when it comes to diabetes, when it comes to maternal mortality and infant mortality. And I tell people all the time, and this is something that they use particularly a lot in like a lot of your business, is that you can't manage what you can't measure. The same thing comes out in healthcare. You can't manage what you cannot comprehend. So it's important for you to understand things such as health literacy, preventive care, and these are the things that's going to help improve your outcomes. And so it always does good to know, and I tell people, you can always look at online like the U.S. Preventive Service Task Force. They actually are what we go by to see who needs what at what time. They have done all the studies and published those things, and it's available to the public. But it's about being able to know what you need and when you need. Okay. So for instance, a lot of people may not need colonoscopies until the age of 50, but that's not the case when it comes to African Americans. You should be getting those at age 45. But not even all medical providers understand that there is a difference when it comes to that. Same thing comes into play when it comes to prostate cancer screenings. And you may have some providers who really don't push for you to get those screenings done just because it is a slow growing cancer. But that is for people who necessarily may not have those high rates. African American men have a much more high rate of prostate cancer and a worse prognosis of it. And even when it comes to breast cancer screening, there are different guidelines, and depending on your provider, whether they may start screening you at age 40 or age 50. But at the end of the day, the information is available for you. You can become literate on those things, and you can push for those. If you want to get a mammogram sooner than 50, then you can talk to your provider and help them to understand why you want to get it sooner. And when you get those things done sooner, particularly for African Americans, such as like breast cancer, you get better outcomes, things get found sooner, and you can get better care. African American women tend to have higher rates of getting diagnosed with breast cancer a lot later and having worse prognosis. So it's very important that you know those things, that you look them up, and you have those conversations with your provider. And let's go to the next thing. And so last two things that I do want to leave you guys with is one, that you should know your rights, okay? At the end of the day, you are a consumer in healthcare, okay? That means you are paying your provider to do their job. And you will not go to, say, your hairdresser and not expect for them to deliver on their services. Your provider is to give you what you need and the services that you need. And with that being said, like if you went to the hairdresser and you didn't like your hairstyle, you won't go to that lady no more, okay? You can do the same thing when it comes to your provider. You can change. You can change. Your insurance or not having insurance limits you to just go to one provider. There are many providers out there for you to be able to choose from. And you can go right on your insurance and figure out what providers are in your local area where you can choose. Because trust and believe, you are paying for them. And without you being a consumer and needing needs for your healthcare, they will not be able to put food on their table and handle things in their family. Okay, so understand that more than anything else, you have rights and you are a consumer, and you have to make sure you hold them accountable in handling, providing you a service. So these are things that you should look to to see when it's time for you to change your provider. When it doesn't seem that they're listening to you, when it seems that they don't have enough time for you. And like I said, yes, most providers, we are held within a time limit on what we can do as far as like maybe 15 or 20 minutes a visit, but they should at least offer you a follow-up appointment to make sure your needs are still getting addressed, or offer you other ways to be able to talk to them. When it seems like your provider is focusing more on your symptoms rather than finding out the actual cause. Again, when it comes to like a primary care provider, their thing is to find out what is the root cause and get you to where you need to be. You don't want to be with someone who's just trying to mask your symptoms. You want to find out what is actually going on and how can we best treat this. The other thing is it's time to move when you have someone who may just be pushing medications for you, okay? Medications are great for some things, but there's other things that's out there. I'm a firm believer that the best medications in the world is exercise and diet, okay? Lifestyle changes are great when it comes to health. And sometimes it may be, let's just try this for at least 30 days or 60 days, and then we come back, you reevaluate it, okay? So you want to have someone that's going to be able to work with you when it comes to those types of things, and take in consideration that you may not want medications, but on the flip end, when you have tried those things, it may be time for medications. And another thing to look to when it may be time to change is if they get offended if you're asking too many questions, okay? If they don't want you to ask questions, you need to get with someone who is not afraid of you being strong and you being an advocate for your health, and who is not afraid of someone who's knowledgeable. Okay. And the last thing is, I want to leave you guys with this acronym, just for you to take with you when it comes to advocating for your health. And these are just a few hints to stick out. So it's called SHARE. And SHARE, the S stands for speak up. Okay. A lot of times, especially when we see titles, we may belittle ourselves, or we may not take in considerations. We may feel like we're beneath them, so to speak. But it's your job and your duty to speak up. Okay. No one is going to advocate better than you. No one's going to advocate better for you than you. No one's going to advocate better for your mother than you, or your father than you. You have to speak up. Okay. Just like you would do with anything else. You didn't like your hairstyle, you will speak up. You didn't like your nails, you will speak up. If you did not like how the mechanic did work on your car, you would speak up. The same thing applies when it comes to your health. And if nothing else, that should be the main time that you do speak up. The H in SHARE stands for hear what the choices are. Okay. There are just not one way to treat something when it comes to your health. There are different options in most cases. And so always ask, what are my options? Okay. What are my options for this? What are the adverse effects from this? What are the side effects from this? Ask for all the complete options so that you can make an informed decision about your health. Okay. The A stands for assert your preferences. Okay. Like I said, your preference may be, let me try better diet and exercise first before I get on this medication. That's your preference. Okay. When it comes to health, it's a shared decision process, and that should be shared between you and your provider. And that goes to the R, reach a shared decision with your provider. Okay. Once you figure out what your options are, you guys make a choice together and you come up with a plan. So for instance, it may be like, okay, I'm gonna give you 6 months to work on your diet and exercise. I'm gonna come back, we're gonna reevaluate your A1C, which is your screening test for diabetes. If it's gone up, the next course of action is gonna be, we're gonna start metformin or some other type of medication. Have a shared decision plan, have a goal for what your outcomes are going to be, and so that you both know what the process is going to be. And then the E comes back to evaluate. Okay. Evaluate your options, evaluate your prognosis, evaluate how things have changed. But a part of that evaluating means you have to follow up with your provider. Okay. So a lot of times, like I said before, when it comes to like health literacy, you just don't know what you don't know. Same thing comes with, okay? We don't know what you don't tell us, okay? We don't know that you may have had a problem with that blood pressure medicine that was causing you an issue in another aspect, okay? There's other blood pressure medicines that we can try, but we don't know that you may have been experiencing something with it that you didn't like, and we could have made a simple fix to change it. Or we didn't know that you had a, let's say, allergic reaction, whether it was a rash. We only know what you tell us. And the worst thing that can happen is that you get lost in follow-up, where you don't come to your next scheduled appointment and we don't know. And then a year down the road, you have headaches, and then you have your blood pressure is even worse control, or yet you had a stroke or a heart attack. So you should always make sure that you get reevaluated after starting any type of medications and evaluate your plan. I always encourage patients, and I try to make sure that no one leaves my office without having a follow-up appointment. And that's for two things. One, if I'm gonna give you an appointment, you're probably not gonna come back. And I need to make sure that, you get the best care possible. So, advocate for your health, speak up for yourself, take care of yourself, and take care of each other. Okay. And so that concludes my presentation for the day. I hope you learned something. I hope you feel more empowered to speak about your health and to be able to advocate for your health. So at this time, I'll take any questions that you may have.
Thank you so much, Ms. Powell, for that empowering presentation. We do have a couple questions here for you, so let me go ahead to those. Now, the first question I came across for you is, how can I advocate for an elderly parent or elderly parents?
So you advocate for them just like you would yourself. Now, I would say this, that sometimes depending on what age they may be and their mental capacity, you may need to have something in writing, at least to be on, or the belief be on the records in that facility that they may be treated in. And that is very simple and easy to do. It doesn't require like a notary or all this legal paperwork that people may think it requires, but it just takes you being to go in, talk with them, have your parents agree on it, and sign. Most doctor offices will allow you to be able to share your information with certain people, whether it's your husband, a child, a parent, and so forth. So you can always advocate for your health. And I always, when I see older people, I always ask them if they're comfortable with me talking to their children. And most of them they are, and if they are, then I let them sign the paper. And then I would recommend, and this is something that I've done with a lot of my older family members, go with them to their doctor's appointments. It's okay. If they allow you to go with them to their doctor's appointments, go with them. That way you can stay abreast on what's going on with them. But that relationship that they have, you can have with their provider as well too.
Thank you. And I have maybe two more questions for you. As a primary care provider, so you are provided, or excuse me, referred to a specialist, and you do not like the specialist. I remember you mentioned that part in your presentation. How much will your PCP advocate for you, or what steps should the patient take? You know, you're like, hey, this one's not it. What can we do? Do we reach back to PCP, or do you move on yourself? What would be your information on that?
You can do both. I would definitely say the first thing, I will definitely let the PCM know, because one thing I'm going to do is I'm going to ask you, well, what is it that you don't like? Because I may not want to refer anybody else to them either. Okay. But the second thing is that when it comes to going to the specialist, sometimes specialties can sometimes be very, very specialized. So you may have, for instance, since we had Dr. Crabb on the presentation early today, you have OBGYNs and but you may have one that's more set into working or more specialized in doing things with fibroids, which is something that's very common. And so even though they may not have the best personality, that may be the best person for your care at that time. So understand that even when it comes to a specialist, they may only be around for a short time just to handle that issue that is going on. Now, if it is something where it is more chronic basis, like an endocrinologist who is we really need to work with your thyroid or with diabetes, there's plenty of those around. Okay, we can refer you to someone else. I always say start with the PCM. That way we can help you maneuver. And the other thing to keep in mind that it's never an issue with asking for a second opinion. Okay. If you feel like even when you go to the specialist that your answers are not getting answered, your questions are not getting answered, it's okay to ask for a second opinion. Did I answer your question?
Yes, ma'am. And last one, I know mentioned in your presentation was about doing your research. Now, Google can be great for certain things, but not all medical questions. Mm-hmm. Now, what journals or what would be the best source to get your best information from? You know, where could we look?
Mm-hmm. And so, Google Scholar is actually open to most people, and Google Scholar, you can actually look for medical journals and things of that sort. So I would definitely say you can Google, but make sure you're getting the good resources. So you can go to peer-reviewed journals in Google Scholar. You can also go on some of the more credible websites. So like you have the American Cancer website that you can go to. You have the American Academy of Pediatrics. You have the American College of Gynecological Association. So most of these areas, they do have a accredited page that you can go and visit. And that at least is a good baseline on where to get information from.
Thank you so much, Ms. Powell. We appreciate all that information. Thank you again for your presentation.
You're absolutely welcome. And happy Mother's Day to everyone.
Thank you. Now, that concludes our question portion for our third installment of our Black Health series. I would like to thank all the viewers who took the time to join us this Saturday to receive the knowledge on provided topics that are so important to our community. Once again, I would like to remind you, if you do have any further questions, please forward them to us at sacdst.org. We will make sure all questions are provided to the appropriate presenter. To our speakers, Dr. Crabb and Ms. Powell, thank you so much today for your time and education on the history of these topics that plague our community and how to stand up for our health. You both are such strong supporters in our community, and this information has been vital. Again, on behalf of Suffolk Alumnae Chapter of Delta Sigma Theta Sorority Incorporated, thank you. I would like to mention our up and coming event in June. This will be our 4th and final installment of our Black Health Series. Date will be announced shortly. The topic we look forward to sharing will be on prostate cancer and also colon cancer. We look forward to another exciting educational event. Please feel free to follow us on all our social media platforms. Have a great day.